Welcome everyone to our citywide psychiatry grand rounds. Thank you for making the time again. And today, our sponsor is UHN. I'm really excited about today's grand rounds. I'm Dr. Raj Rasasingham. I am the CPD Director for the Department of Psychiatry at the University of Toronto. Before we begin, I would like to do a land acknowledgement. I would like to begin with the acknowledgement of this land in which we work, study, and live. Before I read it, I want to take a moment to situate yourself and think about the land under and around you. We recognize that many Indigenous nations have long-standing relationships with the territories upon which the Department of Psychiatry are located that precede the establishment of the University of Toronto. We acknowledge our presence on the traditional treaty of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat people. Today, this land is home to many diverse First Nations, Inuit, Métis people, and we're grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a single land acknowledgement does not capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. Thank you. Couple of housekeeping items. Evaluation link will be sent at the end for attendees, and please give us your feedback. We really appreciate that. Our sincere appreciation to UHN, Dr. Tortier, Dr. Abby, Ari Maharaj, and Suzanne Phillips from UHN for today's presentation. The next citywide grand round is on the 28th, and it's on resource and resilient virtual training programs from Women's College, and we look forward to seeing you there as well. And just a couple of, one other thing, if you have any questions during the grand rounds, I'll be moderating some questions at the end. We only have the Q&A function, so please put your questions into the Q&A portion. Without further ado, I would introduce our Vice Chair of Clinical for the Department of Psychiatry, Dr. Vicky Sturgiopoulos, to do our welcome. Thank you.
Thank you, Raz, and welcome everyone to today's citywide grand rounds. Eating disorders is a very topical theme, especially given recent funding announcements and the pressures we see in all our clinical services from people seeking care for eating disorders. No better site than lead this discussion and inform us of the latest than the University Health Network. I will pass that on now to the Psychiatrist-in-Chief at UHN and Professor in the Department of Psychiatry, Dr. Susan Abbey, who will introduce her co-presenters.
Thank you so much, Vicky and Raj. We're really delighted to have this opportunity to come today to really explore where we're at right now and where we're going. And I'm particularly delighted because we have quite a range of presenters today. Catherine Ford is the clinical program lead for the Eating Disorder Program and a clinician investigator in the Toronto General Research Institute. Her academic home is with us in the Department of Psychiatry, and she's the recipient of an Academic Scholar Award. She will mention herself a little later, but some of her work is built on the very able work done by Marian Olmsted, who is now a professor emeritus at U of T and continues to be our Loretta Ann Rogers Chair in Eating Disorders. After Catherine, we'll hear from Suzanne Phillips, and Suzanne is the program manager of NEDIC. And if you don't know about NEDIC, I think that's going to be the most important thing you're going to learn about today, the National Eating Disorders Information Center. And we're going to also hear from Ari Maharaj, who is our Outreach and Education Coordinator. We can go to the next slide. This is an overview of our agenda. I'm going to just get us all on the same page by giving a quick overview. Then we're going to talk about where are we now, what are the best practices currently in the field, and what's the current Ontario context. And then Suzanne and Ari are going to share with us some of the impact of the COVID-19 pandemic as seen through the lens of NEDIC. And then we're going to talk about where we hope we're going, both in terms of health promotion and prevention, and also in terms of really beginning to re-envision how we provide intensive eating disorder treatment in the current healthcare context. And then I'll just wrap things up briefly. So if we go to the next slide, I think for most people, they think of anorexia nervosa first when they think of eating disorders. We're familiar with the low or very low body weight, the two different types, restricting and binge purge subtypes, fear of weight gain, and disturbance in appearance and perception of an experience, internal experience of body weight and shape, often with an onset in the early teen years, but may have a later onset. And sometimes we have people coming in for their first eating disorder treatment in their 60s, or even a couple of weeks ago in their 70s. The 12-month prevalence is about 0.4% in young women, and there's a 10-to-1 ratio of women to men. Over a 5-year period, the recovery rate is about 40 to 50%. And you've gone ahead of me, Catherine, we can go back one. It's worse for those admitted to hospital. And it's really important to note that a very severe and enduring form of the illness is present in 20 to 40% of individuals over longer-term follow-up. Bulimia involves recurrent episodes of binge eating, and then that's followed by something that in DSM-5 are called ICBs, or inappropriate compensatory behaviors. Any of you who are fans of The Crown will first come to mind vomiting, but there are other compensatory behaviors that people may also undertake. And the severity of it is really dependent upon the frequency at which these behaviors occur. The 12-month prevalence is higher, about 1 to 1.5% in young women, and again, a 10-to-1 female to male ratio, and severe and enduring forms of the illness in 20 to 30%. Binge eating disorder is something that is increasingly recognized, and unfortunately, we don't actually have a treatment program for that at UHN, so I'm going to bypass it. But what I would like to draw your attention to is ARFID, or avoidant restrictive food intake disorder. Typically, that had always been thought to be a childhood illness, but many of the eating disorder programs, both in Ontario and around the world, are seeing increasing prevalence of this disorder. It's really a persistent failure to meet one's nutritional or energy needs with weight loss and nutritional deficiencies or functional impairments. There are a variety of different symptoms that focus often on either a lack of interest in eating or an avoidance of eating based either upon sensory characteristics of food or about concern about adverse consequences of eating. And then OSFED is the most common disorder, and really includes a wide range of things that don't fully meet criteria. If we go to the next slide, because I tricked Catherine out by talking about some of the prevalence data. So here you can see, if you take all of the eating disorders together, it's about an 8.4% lifetime diagnosis in women and 2.2% in men. But if you look more broadly at symptoms, it's even higher. So you can see as high as 19.4% point prevalence in women and 13% in men. The next slide just shows very quickly, and we don't have time to go over it, but the distribution of ED diagnosis and how that has changed a little bit over time as we've moved from DSM-3R, DSM-4, now we're in DSM-5, and sort of there's been some shift in the diagnoses. Our next slide shows the period from 1982 up to 2002 and how prevalence of eating disorders has changed over time. And if we go to the next slide, you will see data there that shows 2000 up to 2018. So some people have queried whether this increasing prevalence is a result of greater awareness of these diagnoses, of changes in the way in which we measure them or screen for them. But some research that has looked at more consistent measurement practices and self-reports really do believe that the prevalence is increasing over time, and that at this juncture, really OSFED is the most prevalent disorder. Who are the people with eating disorders? In our next slide, I think historically, it's been thought of as a disorder of Western culture and primarily affecting white women. And that has really, I think, influenced how we have approached these disorders and how we've treated them. This is a wonderful poster that I love that says eating disorders are as diverse as the people they affect. And it really calls us to bring our EDI lens to eating disorders. If we go to the next slide, we'll see that there are a whole range of groups of people with eating disorders who we are not thinking about in making the diagnosis, who are not screening appropriately, who are less likely to be diagnosed, who are less likely to receive treatment or to stay in treatment. And so we really have to check our own biases. We have to look at groups that are at higher risk: transgender and gender expansive individuals, sexual, racial, ethnic minorities. A huge amount of work has been done on the association between eating disorders and interpersonal trauma, and in particular PTSD, and Catherine has significant expertise in that area. And most individuals have other comorbid psychiatric disorders. We've been very interested in looking at the timing of treatment of these disorders, but now with the tsunami of cases, we're sort of pulling back from that a little bit. If we go to the next slide, really some statistics about the impact of eating disorders. Worldwide, over 3.3 million healthy life years are lost each year due to this. Healthcare costs are 50% higher in individuals with eating disorders, and anorexia nervosa has the highest mortality rate of all mental illnesses, but at about 10%, and about half of that is through suicide and half is through the physiological consequences of the disorder. What we've realized more recently is that mortality is also elevated in other eating disorders, and Ontario data shows that there's a 5 times higher mortality rate for those who have been treated in hospital than for the general population. So I'm going to turn it over to Catherine now to speak about evidence-based treatments for eating disorders.
Thanks, Susan. So we do have a number of evidence-based treatments for eating disorders, which is a great thing. There have been a good number of randomized controlled trials of CBT, particularly for bulimia nervosa and binge eating disorder, but also for other similar profiles. The highest evidence does exist for a specific cognitive behavioral therapy called enhanced CBT or CBTE. And interpersonal psychotherapy is also considered an evidence-based treatment for eating disorders, particularly bulimia nervosa and binge eating disorder. Unfortunately, we do not have a treatment that we can consider evidence-based for anorexia nervosa. There is evidence supporting the use of CBTE for anorexia. However, it has not been shown to be superior to other specific protocols that have been tested in the trials. So the good news is there are other treatments that show benefit as well. There are also some interesting emerging treatments for severe and enduring anorexia nervosa, a specific CBT protocol, and also a specialist supportive clinical management protocol. And then for adolescents, family-based treatment, referred to as FBT, it's a specific protocol, is the evidence-based treatment for adolescents with anorexia nervosa, and that treatment can also be used with adolescents with bulimia nervosa. In terms of the continuum of available psychosocial eating disorder treatments range from outpatient, group, and individual therapy at the least intensive end of the spectrum, up to day hospital, residential, and inpatient treatment at the more intense end of the spectrum. Currently, evidence-based treatments only exist at the intensive individual outpatient, at the outpatient individual therapy level. The randomized controlled trials are lacking to be able to say that these other treatments are evidence-based. And in particular, randomized controlled trials are lacking to show us when the more intensive treatment programs are needed, when they might be of benefit to people, or even if they're of benefit at all over and above our current evidence-based treatment. The current practice guidelines do suggest that treatment should take place in the least restrictive setting possible for the patient, and that the benefits of more intensive treatment should be evaluated regularly for any given patient, given potential negative side effects of more intensive care and being in hospital. We do have a number of practice guidelines to guide our care of people with eating disorders, which is excellent, including 2 recent Canadian guidelines that I encourage you to check out. I did want to highlight that the guidelines from the APA are from 2006, so they are considered quite outdated at this point. Overall, the practice guidelines, of course, recommend the evidence-based treatments that I just shared with you. They also generally support the use of guided self-help, particularly for bulimia nervosa and for binge eating disorder. In terms of psychotropic medications, so far they have been shown to be of limited benefit in anorexia nervosa. There is some benefit of antidepressant medications in particular for bulimia nervosa and binge eating disorder. However, the effects of those medications are in the small to moderate range compared with more large magnitude impacts of our current evidence-based psychotherapies. In terms of the current state of the system in Ontario, unfortunately, Ontario lacks an organized system of care. There's a lack of coordination in the system, so individuals might be referred to multiple eating disorder programs simultaneously, which does use up very precious resources, and they might also be referred to programs that don't meet their needs. So they're referring physicians or practitioners would be referring to programs that they're aware of or the programs in their area that may or may not be the right program for that patient. Unfortunately, services are not currently accessible across the full continuum of care throughout the province. So there are large gaps in services that vary by region. Also, our current system does lack a foundation in evidence-based treatment. So it's up to the individual eating disorder program, what type of treatment they provide currently. Just as an example, currently cognitive behavioral therapy enhanced, so our evidence-based treatment for eating disorders is not available in the GTA through publicly funded programs. To access this treatment, you would need to pay out of pocket. And that puts you in a position of getting a treatment where there's no quality assurance. And we do know that in clinical practice, clinicians tend to veer away from those protocols. So there really is a dire need for this treatment to be available through our publicly funded system. Some of the consequences of the current system are that most individuals, unfortunately, do not receive treatment. That's the great majority of individuals. And many individuals do not receive an appropriate treatment. So they don't receive a treatment that's known to work, or they receive a treatment that may be too intensive for what they need, or maybe a treatment that's not intense enough for their needs. Unfortunately, many individuals are not receiving treatment until they have been ill for many years or have severe illness. And our current situation is that a very small proportion of affected individuals with eating disorders are receiving a high proportion of our available services. Unfortunately, the COVID-19 pandemic has come along and exacerbated the situation in terms of our system. And I'm going to pass things along over to Suzanne from NEDIC to share more about the impact of the pandemic and the work that NEDIC is doing.
Thank you, Catherine. So the National Eating Disorder Information Center, NEDIC, is a program of UHN Center for Mental Health. NEDIC was founded in 1985 and mandated to provide information, resources, and referrals to those impacted by eating disorders across Canada. So we have the only national toll-free helpline and instant chat services dedicated to eating disorders for Canadians. We also have a searchable online directory of 700 plus treatment and support providers across Canada. So those include fee-for-service options, provincially funded programming, and free options located within the community and at universities. Our prevention work through education, so resource development and training in the community, along with running health promotion campaigns such as Eating Disorders Awareness Week, February 1st to 7th every year. Next slide, please. So looking back at the beginning of the pandemic in 2020, what we were hearing from individuals connecting with us on our helpline and via instant chat was around sort of a lack of access to treatment, people indicating worsening symptoms. So individuals who may have been in a good place of recovery and COVID had caused a setback. Those feelings of being out of control during quarantine and an increased need for support. We also started hearing from a lot of individuals who were connecting with us and indicating that pre-pandemic, they had never experienced disordered eating, but during the pandemic, isolation, changes to their normal routine, social media, had caused them to engage in disordered eating behaviors. Next slide, please.
the next couple of slides we're going to talk to you about show some data from NEDIC services. And so this first slide covers off some data from that initial pandemic period, March 1st to April 30th, 2020. And I want to really spotlight underage, that 29% of teenagers 15 to 19 years old who were reaching out to us. That's a big jump for our services previously. That number was around 12.69% in 2018 and 11.22% in 2019. And a lot of the themes that came up on our services during that time talked about what Suzanne was mentioning earlier. The normal social supports and structure of school or work were disrupted. Folks being unable to find respite at home with family members, and that lack of routine. And it begs the question that this age group might need to be targeted with better support options during times of crisis. I also want to highlight on the slide the amount of folks who are undisclosing or undiagnosed who are reaching out to us. NEDIC's helpline services are anonymous and confidential, and we don't require a self-referral for folks to reach out. And so many folks might not have had a diagnosis previously, or many folks have been in a transient state around that. And it begs the question, the amount of Canadians who are impacted by disordered eating, even as a subclinical condition, that should be on our minds as we're thinking about assessment and treatment later on. Next slide that Suzanne's going to walk you through are going to cover off 3 pieces of information from NEDIC services spanning a larger time period.
Thanks, Ari. So looking at, quickly, I'll note that our fiscal years are April to March. So when we look at 2019 to 2020, we are capturing a very, very small piece of the initial COVID pandemic. And when we compare it to our 2020 to 2021 period, we saw a close to 60% increase in individuals who were accessing our direct client support services via helpline and chat. Next slide, please. I want to walk you through this one because I think that this is sort of the most telling about individuals and the impact of disordered eating. When we look at the first 6 months, so April to September of the 2019, 2020, and 2021 fiscals, we see that the increase from pre-pandemic to the initial first wave of and second wave of the pandemic, there was an increase of 57%. When we look at the first 6 months of 2021, we're seeing 125% increase in individuals reaching out to us compared to pre-pandemic. Next slide, please. So just wanted to point out a few similarities and differences looking at the 2019 pre-pandemic period and the 2020 fiscal. So where you see the dark green are where we've seen sort of marked increases. So individuals choosing to connect with us via instant chat, we've seen a marked increase, along with the amount of individuals connecting with us, and it was sitting in that period at an increase to almost 25% of those connecting with us who were looking for resources that they could utilize. When we look at some of the other data, we see a 8% increase in those connecting with us who are directly impacted. We see things remaining very, very much the same with the number of individuals who are reaching out to us into our extended hours in the evening. We have seen a marginal increase in those connecting with us who are under 25. I think the big thing to note is the number of secondary clients is remaining steady. So individuals reaching out to us about somebody who's impacted by an eating disorder being under 25 is sitting at 2/3 of those contacts. It's also worth, when we're looking at resources, to note the traffic to our website. In particular, I will highlight that we saw a 185% increase to site visits on our Helping Your Child page. Next slide, please. So many of the referrals that NEDIC has been doing have been to community-based organizations who are providing support services. So these services weren't meant to be a replacement for psychotherapies. And we've noted that the programs based in those communities have seen a huge uptick in demand for the programming that they are offering. For a global context, want to mention that when we look at our partners at NIDA in the US, BEAT in the UK, and Butterfly in Australia, who also operate national helplines and chat services, they've seen marked increases to service demands to up to 195% in the UK. I want to quickly note that NEDIC has entered a pilot program with BEAT in the UK for shared chat services. This allows us to reach more individuals who are impacted and needing our services. So during the evening, NEDIC is supporting individuals in the UK late into their what is their evening via their chat platform, and BEAT is supporting Canadians via NEDIC's chat platform on the weekend. So really that's allowing sort of NEDIC to be operational almost 365 days a week.
The next 4 slides are going to cover off different pieces of research. The first 2 ones in Ontario and the last 2 ones internationally. These first 2 slides are courtesy of ICES, formerly known as the Institute for Clinical Evaluative Sciences, and I think are really convincingly showing that Ontario experienced a 66% increase in risk for emergency room visits, emergency department visits, pre-COVID to during, really in that pediatric system. So I'm going to refresh your memory a little bit. And so seeing that teenagers were a big demand increase for us on our helpline services. And we're seeing here in Ontario, at least specifically, that folks are noting that in emergency room visits as well. On this next slide, you see that Ontario's experienced a 37% increase in risk for hospitalizations in Ontario. So pre-COVID to during for pediatric eating disorders, again, not just emergency room visits, not just folks calling our helpline, but also folks needing to use hospital-based services there too. As we turn our attention to findings from international research, it's really important to note that these things are being corroborated across across the world and globally. And some of the research I'm going to show you now is really focused in on parts of the English-speaking world. So here, in a large study using electronic health records of 5.2 million people under the age of 30 in the US, diagnostic incidence was 15.3% higher in 2020 overall compared with previous years. And again, even though that data is under 30, the authors there noted specifically that increase in 10 to 17-year-olds. And in a systematic review that's really wonderful to check out in the International Journal of Eating Disorders, you're noting both symptom escalation and mental health worsening, both with an increased demand for services. And I think what's really important to keep in mind as we turn our attention to the second half of this presentation is that while the forced transition to online treatment was challenging for many, it's important to note that telehealth alternatives seem feasible and effective. And as we talk more about access for folks who are impacted by this issue and have had a historically and presently a really tough time accessing support, telehealth treatment is something that we'll have to pay more attention to. On that next slide, just going to note some commonly reported experiences so you have that for your knowledge toolkit. The anxiety due to disruptions in living situations and treatment options changing, a decline in general mental well-being, an eating disorder not just about food, but something that can really find its way into other parts of your life, and things like social isolation and loneliness can really corroborate that. Greater numbers of eating disorder admissions with psychiatric comorbidity and suicide risk during that same period in 2019. And really important here, an increased burden on carers. As Catherine noted earlier, family-based treatment is our evidence-based treatment for adolescents, and carers, loved ones, friends often are really involved in someone's care, especially in the ways in which eating disorders affect someone's eating and movement-related behaviors. And that burden, I think, is not something that we've generally seen highlighted in the way in which we're talking about this issue. We're now going to turn our attention really briefly into where we're going, because importantly, I think promotion and prevention work has to play a piece in the puzzle when we're thinking about eating disorders. Right now, especially when our funded system of care is a whole lot of nothing, 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 nothing. Oh, you're really sick. Here's an intensive hospital-based support. We're missing a lot of people, like Catherine's saying, and I'm personally really worried about that iceberg. So on this next slide, you can see some of the work that NEDIC and some of our partners are doing to try to combat that and meld that gap. So in our outreach and education programming, we're really focusing in on a lot of work with school-aged youth. So folks in middle school, high school ages, really working on protective factors for eating disorders. So things like body acceptance, helping people develop a relationship of trust with their body, developing critical social media literacy skills, and we're seeing positive feedback for that. We're also able to talk a lot with educators in the school system, both within the TDSB for us local GTA folks, but also folks now across the province and across the country with the advent of virtual and Zoom and Google Meets and these virtual ways of us streaming into classrooms that our lovely volunteers and students and folks like myself are able to help bring eating disorder risk factor content, not talking about eating disorder specifically, but those risk factors there to youth to try to buffer them from developing an eating disorder. And part of this work in our next slide is starting to be work that we're also seeing across Ontario funded in a different way. So the recently announced Eating Disorders Promotion, Prevention, Early Intervention Initiative is really meant to fill a gap in service delivery on this promotion prevention side. And you can see on this map of Ontario, the different partners from across the province who are involved with this, folks in the Northwest, folks in Ottawa, folks in Windsor, and folks in Sudbury, and NEDIC and UHN, and here in Toronto. And really thankful for the work led by Dr. Gail McVeigh at UHN at the Ontario Community Outreach Program for Eating Disorders in this area to really create a system of care that is going to be able to buffer those folks who are experiencing disordered eating and the youth who are really vulnerable. In our next slide, you can get a sense of what that continuum of prevention is starting to be looked like. It's really important to note that this is still in a build phase, but these are research-based strategies that are coming out that have evidence behind their approaches. So things like in the universal prevention end, thinking about weight bias awareness and prevention training for service providers, some skill building for youth around media pressures, and around some of the key normative stressors of early adolescent, and introducing as we get more and more closer to risk, some CBT-based skills to really target things like social anxiety and perfectionism, and things like body dissatisfaction or early signs of disordered eating, all the way up to early intervention capacity building among professionals. And without further ado, I'd like to turn that over to Catherine to talk about what the UHN Intensive Eating Disorders Program is contributing to.
Thanks, Ari. So I'm really pleased to be able to share with you today an overview of our adult intensive eating disorder program at UHN and how we have been working to best meet the needs of our patients and also the demands of the current healthcare context. So just very briefly, the program at UHN is an intensive eating disorder program for adults. So we do serve people who are 17 years of age or older. We treat all eating disorders of moderate to extreme severity, except binge eating disorder. We have a 10-bed inpatient program. We do have both harm reduction and remission streams in the program. And then we have our day hospital program, which has now been redesigned into a virtual care program. Treatment in our programs is voluntary and not for those who require emergency life-saving intervention. So those folks do need to be seen in medicine. I've included a link to our website if anyone's interested in taking a look at a more detailed overview of the program, and you can also find our referral form there in case you are in need of it. This slide shows the goals of our components of the program, so our intake process, as well as our inpatient program and our virtual intensive outpatient program. I wanted to highlight that the goals of inpatient treatment are medical improvement, getting people eating an adequate amount, helping people to restore their weight, get that process going, and to interrupt symptoms like binge eating and purging. The psychological care in the inpatient program supports those goals, whereas in our intensive outpatient program, we also focus on those behavioral goals, and the psychological care also focuses on addressing factors that we think is contributing to the eating disorder, keeping the eating disorder going. We have been undergoing a process of redevelopment in the program. Substantial redevelopment started in 2016 with a launch in 2017 under the leadership of Dr. Olmsted and Dr. Colton. And it's gone through another major iteration in the context of the pandemic and the need to provide virtual care in our outpatient program. Dr. Olmsted and Colton led us off with redesigning the program with core patient care principles in mind. So those patient care principles we've continued to follow, and I think we've added a little bit to them and solidified some. They are individualized care. So we want to be able to provide individualized, flexible care that meets our patients' needs rather than cookie cutter care. We want to have a foundation in evidence-based treatment in our programs. We want to focus on building autonomy and agency and recovery in our patients. Relapse rates are very significant in eating disorders, particularly following intensive treatment. So this is quite important for us. We want to minimize the use of restrictive environments and prevent possible iatrogenic harms of intensive treatment. We want to decrease barriers to accessing treatment. This is becoming all the more important as we know there are so many people who are not accessing care right now. And finally, we also want to reach the greatest number of individuals that we can with effective treatment. So although great effort was put into redesigning the program in 2016, 2017, in line with these patient care principles, what we found is that we were redesigning the program within the box, particularly with the outpatient program of an all-day in-person day hospital program. So that really limited our ability to fully address some of these patient care principles, like building autonomy and agency and decreasing barriers to treatment. An all-day in-person day hospital program in Toronto is a very high barrier. So in order to access that program, people had to be able to either be living in Toronto or be able to pay for housing in Toronto for a period of at least 4 weeks, but usually 6 to 8 weeks. This figure, the iceberg analogy, depicts some of the critical gaps in care that we're trying to address with our patient care principles and our program redevelopment. And this comes from a paper written by Alan Kasdan. So what it shows is that a minority of people with eating disorders are getting some kind of treatment right now. So only 20% of people are estimated to be getting something, any kind of treatment. 80% of people are estimated to be getting nothing, which is highly concerning. Kasdan has argued that we need to put our absolute best effort into making sure that the people who are getting services are getting high quality evidence-based treatments that are known to work. And then he's also made the point that in order to start to be able to reach this 80% of people who are currently getting nothing, we need disruptive innovations in the system. This is all the more important now as we see the prevalence of eating disorders continues to increase, and we may very well be facing a very big increase in eating disorders in the context of the pandemic. So I'm going to share with you some of our program redevelopments that we've made and some of our program evaluation data. And before I do that, I just wanted to acknowledge the work of our colleague, Dr. Danielle McDonald, who has done a great deal of work on our program evaluation and did a lot of work in helping to prepare the data for today for us to be able to share with you. So looking at our inpatient program, one of our goals has been to increase the number of people served with our 10 beds that we have and to ensure equitable access to those beds for patients who are new to the system and new to our program. So over the last few years, we have increased the number of admissions overall by 40%. And if you look at the data that's presented there, this shows the number of the percentage of patients who are new to the inpatient program versus readmissions to our inpatient program. You can see that the proportion of new patients admitted has been up by 21% over the last several years. And our beds are now available to a wider range of people with eating disorders. So not just people with severe anorexia nervosa, but also people with, for example, extreme frequency bulimic symptoms, essentially anyone with an eating disorder where we think hospitalization is indicated. So how have we been able to do this? We've done this by shortening the length of admission to the program. A typical admission for an underweight patient is now about 6 weeks. It may be less for someone with harm reduction goals. So you can see, looking at the data on the far right is the past year, the far left in 2015, 2016, length of admission in the program has reduced greatly over time. Shortening the length of admission has allowed us to reach more people. It also helps us to meet our patient care principles around treating people in the least restrictive environment and potentially preventing negative side effects of hospitalizations. These changes are in line with other treatment centers. So we are aware that Ottawa has also reduced their length of stay, similarly to us, and St. Paul's program in Vancouver has a standard 6-week length of stay where patients need to leave the program after 6 weeks. So patients know they've got 6 weeks to work with in terms of their treatment. We were really happy to see that although length of stay has been shortened quite a bit, BMI outcomes at discharge from the inpatient program are very similar over time. So you can see on the right that previously in 2015, 2016, in a 14.6 week on average length of admission, patients left on average at a BMI of 18.6, and now at a 5.5 week admission, patients are leaving at a BMI of around 18.2. So how have we done that? We've done that by implementing a standardized, more aggressive refeeding protocol and discontinuing the previous practice of low and slow refeeding. This has been based on emerging evidence that more aggressive protocols are safe and have benefits, including shorter time in hospital and reduced exposure to starvation and being underweight. So I'm now going to share a little bit about our day hospital program developments and evaluation. For us, the pandemic silver lining was really allowing us to truly envision what the day hospital could be rather than what it was before. We had tried to do this before in 2016, 2017, but we were redesigning within the box of an all-day in-person day hospital program. We were providing almost all of our patients' food to them. We gave them some opportunity to practice, but overall we were providing and preparing most of their food, and we were using a controlled, contained environment as one of the major therapeutic agents. So going back to that principle of Kasdan of needing to have disruptive innovation in order to make leaps forward in mental health care, and in particular in eating disorders, virtual care happens to be an example of a disruptive innovation. So with the pandemic and the need for us to develop a virtual program, this enabled us to potentially reach many more people. And it also allowed us to step outside of our box of an in-person all-day program and disrupt the status quo. So our first major decision that we made in the program design was that we would not simply translate the existing program onto a virtual care format, but rather we would redesign the program based on our patient care principles. So you can see those patient care principles there on the left, and you can see what our current program looks like on the right. So the next major decision we made was that the program would need to have a foundation in evidence-based treatment. And we decided that meant delivering a course of individual CBTE to every patient in our outpatient program. So you can see on the bottom right of the slide, that's the foundation of our program. We decided that all other components of the program would need to be complementary to the individual CBT and support the work that the patient was doing in CBTE. So you can see that we added daily meal support, daily skills groups, including DBT skills, nutrition self-management skills, helping patients to be able to grocery shop, prepare food, etc. And then there's also individual counseling from occupational therapy, social work, and dietitians available as patients may need those. We decided that we would layer on only what we thought was essential to our patients having good outcomes, given that our patients are on the more ill end of the spectrum, and they may be patients who have not responded to previous outpatient treatment. So this is an overview of the previous in-person day hospital program and the current virtual intensive program. So you can see a big difference is the number of hours of treatment per week. Previously, the program was approximately 30 hours per week, and now it's only 13 hours per week. Before, patients were in a controlled, contained environment. Almost all of their food was provided and prepared by the program, and we had a prescribed meal plan, whereas now patients are at home in their own environment, preparing their own food, and they work on improving their eating over time. I'm going to start by sharing some program evaluation data. It's very early program evaluation data. We've just pulled this together to take a look for ourselves and share it with you. I wanted to just share before I get into the data that when we first reopened our program to be virtual, we provided cognitive behavioral therapy enhanced, CBTE, on its own, so outside of those intensive treatment and aspects. We did that because staffing was tight during the pandemic, and also because we wanted to train our staff in the evidence-based treatment. So what you're going to see when I present data on the virtual program is data that's lumped together for CBTE by itself and CBT in combination with all those intensive treatment elements. So I'm going to show the data in subsets of patients. So patients first who transitioned from the inpatient program versus who were admitted directly, and then subsets of patients who are underweight and have binge purge symptoms. So looking first at underweight patients who transitioned from our inpatient program. So if you look on the right, the blue bar is our virtual program and the yellow bar is our previous in-person day hospital program. So what you can see is we have a very similar BMI outcome at the end of treatment, despite having many fewer hours of treatment and patients being at home in their own environment, learning to feed themselves without a prescribed meal plan. We used to also have a prescribed target weight of a BMI of 20, and now we provide psychoeducation around healthy weights, what's likely to be a healthy weight, and we just help people to work on improving their eating and moving along to a healthy weight. And we can see that they end up in a very similar place, which was very exciting for us. Now looking at patients with binge purge symptoms who transition from inpatient treatment. So on the right, you'll see the data for virtual care, and on the left, previous day hospital treatment. This is remission rate. So we define remission by having remitted would be no binge purge symptoms for a month for the last month of treatment, whereas partial remission is having no more than a few symptoms in the past month, and not remitted is anything more than a few. So you can see that remission rates are very similar, as are the partial remission rates with the current virtual care program versus the previous day hospital program. And again, this is despite many fewer hours of treatment and patients being at home and not in a controlled, contained environment, for instance, where the washrooms are locked after eating. This graph shows eating disorder psychopathology. So this is one of the gold standard measures for outcomes in eating disorders that we can look at transdiagnostically, so across different diagnoses. It's measured by the eating disorder examination interview. So what we can see here is that there may be a little bit of benefit of the previous day hospital program over the virtual care program in terms of improvements in EDE global score. So this is something that we're going to keep an eye on over time. This graph here is the clinical impairment assessment. This measures how much impairment someone's experienced related to their eating disorder. So here we can see that patients in the previous day hospital program and in the virtual care program are ending up at very similar places, although our previous cohort did start off a little bit more impaired than the current. So now looking at patients admitted directly to virtual treatment. So these are patients who did not first start in the day hospital program. So this is patients with binge purge symptoms. And I'm only going to show you those patients today because we don't yet have data, enough data to show our underweight patients. So what we have here on the far right is data for the virtual care program. And then in the far left and center is 2 previous years of day hospital data for comparison. The same remission definition. So remitted being no binge purge symptoms at all for the last month of treatment, partially remitted being no more than 3 episodes in that time period. So again, you can see things look very similar with the virtual program to the previous day hospital program. This is looking at eating disorder psychopathology. You can see again, the pattern of change is very similar with the previous day hospital and virtual care. And it's the same story with clinical impairment related to the eating disorder.
1 minute, Catherine.
Okay, thank you. So really quickly, our learnings from the virtual program so far are that end of virtual treatment outcomes appear to be very similar to in-person treatment, despite more than 50% fewer treatment hours. We think this is pretty exciting given that patients are in their own environment and they're really doing this for themselves. We think the skill acquisition is really essential to good outcomes. And we think that the fact that we're providing evidence-based treatment is a big factor in that. Super quickly, we did break down the data to look at CBTE by itself versus intensive treatment. And there's some interesting things there. It looks like CBTE on its own could be just as good as intensive treatment following inpatient admission, whereas those admitted directly to virtual care, the intensive program looks like it might be a bit better than CBTE by itself. So that's something that definitely needs further research. Where are we going? I'm going to turn it over to Susan.
If you can go to the next slide. So we're going to continue this work. If you go to the next slide, Catherine, there are some very significant groups who we need to do more work on. What do we do with people who are really sick and they don't benefit from our existing treatments? What do we do with people who have had repeated admissions and it hasn't been beneficial? How do we get outpatient CBT available to people through the publicly funded system? And how do we provide some treatments for those with severe and chronic illness? I hope I've convinced you that the received wisdom in the absence of evidence is a problem. If we go to the next slide. It's important for you to know that the Mental Health and Addiction Center for Excellence in Ontario Health has identified eating disorders as an area of priority. Eating Disorders Ontario is the new incarnation of the Ontario Community Outreach Program for Eating Disorders, and we really do need a coordinated system of care. If we go to the next slide. And reaching out, I think, to minority groups and taking an EDI lens. And if we go to the final slide about what can you do individually, well, be informed, and you've already started doing this today. You can screen your patients for eating disorders. There is a wonderful 1999 5-item self-report that you can use with patients called the SCOFF, and we have the link for that there. Consider adding CBTE to your toolkit. It's available free of charge, and connect your patients with NEDIC's free anonymous helpline and chat services to help them navigate the healthcare system. So we'll turn it back to you, Raj, and we can open for questions.
Thank you. Thank you, Susan, and the team. It's a really thought-provoking presentation. Maybe we can ask the team to come up on screen if they would like. It'd be nice to have them on camera as well, and we can jointly ask some of the questions. I mean, there were some interesting questions, and we'll answer a couple of them in the time remaining. There was a question on, is there any research into IFS as a therapeutic modality for eating disorders? I think they're talking about internal family systems models for therapy. Any thoughts on that from the group?
Ari was nodding his head, so I thought he maybe knows about it. I think that there's a lot of interest, but I don't think there's a lot of data yet.
Yeah, that's where that is. So internal family systems is just another psychotherapeutic model. Dick Schwartz, the founder, I think really tried to build that model off of some work that was initially done for patients with eating disorders. But in terms of when we're talking about what would qualify as evidence-based data, to the extent that Catherine was talking about earlier in the presentation, I don't think we're there yet. So again, maybe a piece of emerging evidence to keep your eye on, but that's where we are with IFS.
Thank you. There's, obviously, I think everyone is intrigued by the use of virtual care models in the integration of care with eating disorders. Could you talk a little bit about, the evaluation of technology in the use of eating disorders and the modalities? I mean, how is that that coming out in the research or the evaluation that you have done?
Sorry, Raj, do you mean that, sorry, I'm just wondering about, you don't mean the comparison of the outcomes of the virtual care, you mean, what part do you mean? What patients think about the technology?
I think the outcomes, of using virtual care as a mode for treating eating disorders.
Oh, okay. So beyond our data. Yeah. I think it's really just starting to emerge. And there hadn't been much data previously, but I think overall the picture does suggest that the treatments are probably equally effective. And I think what's going to be really interesting is the long-term follow-up data. So what's going to happen with relapse rates? We're hoping, particularly in intensive treatment, that people being at home in their own environments and having to really do this work for themselves is going to translate into improved relapse rates. So I think that's a big hope in the field, that we might have had a disruptive innovation here in that we can reach more people, but also that not keeping people in these contained and protected environments for longer than we need to may actually help us improve outcomes in the long term.
Thank you. There's been really some intriguing questions on CBTE, and can you talk a little bit about why it's so effective and in terms of eating disorders, it's sort of one of the gold standards, right? So
yeah, I mean, it is certainly the treatment with the highest evidence base, and it is quite effective. Does it work for everybody? No, it doesn't, but it does work for many people. 70% of people probably have pretty good outcomes with CBTE, and so it's important that we get that treatment out to people. I think it's a protocolized treatment, which is really important. So people are getting a therapy package. And CBT really aims at trying to target the psychopathology underlying the eating disorder. And I think that's really important. So the overvaluing of weight and shape and controlling eating that we see in eating disorders is a major target of the treatment. It also helps people to really get outside their eating disorder. So we see this real preoccupation with eating, weight and shape, and eating disorders. Life becomes very narrow for people with eating disorders, and the treatment really helps to get people out of that and to start engaging with their broader life in the world outside their eating disorder. So I think those are some key things, and really helps the patient own their recovery and do this work for themselves.
I think you've talked a lot, Catherine, about part of the work is figuring out, how do I take care of myself? How do I feed myself? How do I make food? And those things, rather than having them kind of imposed on you.
There's some really good questions about, is there some type of plan of just kind of expanding some of these modalities in the way that you've made some changes to Northern Ontario and other hospitals? Is there, I know you mentioned a little bit about some of the networks. Is there some thoughts about that? Have you heard anything in the system?
Great question. So actually in the coming weeks, every once a year, OCOPED, so that's the Ontario network, does host a network meeting where they bring everyone together in the network. And so I'm going to be sharing this information with the network in a couple of weeks, and we're going to start to have conversations about these things. And I know Eating Disorders Ontario and the Center for Excellence are very interested in these questions and what should the system look like? How do we have a foundation in evidence-based treatment? Lots of very interesting things to talk about. And I think we really need more data in order to help guide our service delivery, given the amount of need and the limited dollars.
There was some really good questions about asking more questions about this harm reduction stream approach. Any thoughts on that? I know you've probably done some background work before developing the program. Thought?
It's certainly a work in progress, but we did identify, back with the redesign under Dr. Olmsted and Colton's leadership, the importance of having harm reduction options or pathways in the program. So really it's a work in progress, in that we're always trying to figure out what does this look like? What should it look like? What makes sense? And I think a question that we're often facing is this a good use of beds and inpatient admission? So right now, what we're doing is, if people if they don't have the goal of remission, but they do have the goal of substantial change, they want to make a substantial change, then we're happy to admit people and help them to meet those changes. They might not move on to CBTE in our program, which is more focused on remission. And we hope that we'll be able to maybe have some outpatient options, some outpatient individual therapy options for harm reduction. That's an interest of ours that we hope to be able to turn our attention to as the pandemic dies down, and maybe we have some more hours available to us.
I'd also say I've been really impressed at the at the really significant impact that harm reduction has had to really enhance quality of life in a significant subset of our patients and to really let them have much better lives. And, you know, they were precluded in treatment in the past because they didn't have a full remission goal. So I think it's really important that we look at that as we are in many other areas of mental health and addictions.
Absolutely. I know there's some question. I don't know how much data is out there. Questions about COVID-19. Is COVID-19, is there some type of relationship between anorexia nervosa and COVID-19 or post-infection, something similar to the PANDAS, they used to talk about with OCD. I mean, is there any data on that, or just a question from the audience?
I have to say, I have not heard about this.
Okay.
I don't know if others have heard anything, but this isn't something that's
yeah, no.
I bet Nedic's heard a lot about the stresses that COVID-19 has caused family systems, right?
Yeah. Okay.
Yeah, and I'll just answer quickly to say that I think there's been some really exciting emerging research in this area. Like, I think we're heartened by the amount of new research funding that has been applied to being able to fund more studies with eating disorders. And COVID-19, I think, has elevated the profile of it. And I'm excited to see things in this area going forward, but not something on the PANDAS level that I think we've seen yet personally. And that might be limited, like others have noted.
Okay. One last question, and I thank you for this engaging talk. And it's really, this pharmacological options, it seems quite limited in the eating disorders. There was some buzz about olanzapine at one point having some benefit and stuff, but then it didn't really pan out either, right? So is there anything that we see, anything in the horizon, Susan? Or?
I mean, I think we want a magic bullet, right? We want a magic bullet, and who wouldn't? Yeah. I think primarily the role of psychotropic drugs is in helping people control their anxiety, control their overactivity to allow the rest of treatment to be effective. I think there's some new interest in psychedelics and whether those may be helpful in eating disorders, and hopefully we'll have some more to bring back to you about that in the next couple of years.
Thank you, everyone. I really appreciate the time. It's really been engaging, and I think it's very useful to our audience. So thank you. I appreciate it. And hopefully we'll see the rest of the audience at our next Grand Rounds, the Women's College Grand Rounds that's going to come up in January. Take care.
Thanks so much for having us. It was great.
Welcome. Bye.